So, how can we prevent extubation failure? These are my conflicts of interest. To prevent something, we should know first why this phenomenon occurs. So, why we can develop post-extubation respiratory failure? This is due to several factors, and the weaning and the extubation actually induced several changes at the upper airway level. So the upper airway changed their status, but also we have change in the lung status, in particular lung aeration. We know that extubation may be associated with loss of aerated lung volume. We have change in hemodynamics. We change the intrathoracic pressure, of course, and also the neuromuscular function may be affected. So all these factors may play a role, and in some patients may create an imbalance between the respiratory muscle capacity and load. And this imbalance may form the basis for the developing of post-extubation respiratory failure. And I underline the fact that all these are important, but the loss of lung aeration seems to play an important role in this context. And that's the reason why when we talk about prevention of post-extubation respiratory failure, we very often associate this with use of device that may increase lung aeration or at least counteract the loss of aeration associated with the weaning and extubation. And we have several non-invasive techniques for non-invasive respiratory support that can be used. Of course, classically is the non-invasive ventilation, both with face mask. In general, it's face mask in terms of CPAP, in terms of pressure support. And then we have some other devices that has been used in the last decades, which is iFlow, and more recently, obviously, helmet has been used most in patients with hypoxemic respiratory failure, so before eventually intubation. And the reason for that is that, of course, all these devices offer have physiological effects that may be beneficial in these patients, particularly, remember, in context of trying to impede, counteract, reverse loss of lung aeration associated with weaning and extubation. For example, CPAP and non-invasive pressure support ventilation, so with two level of PEEP, B-level ventilation. Of course, increase the pressure inside the lung. This, from one side, may enhance ventilation, especially when you have pressure support, decreasing CO2, but you can also recreate the lung because you apply PEEP. You may decrease the inspiratory effort and respiratory rate. Of course, you can have a higher and stable FiO2. With iFlow, we have other physiological effects which are beneficial. Control of FiO2, but with iFlow, the nasal flow creates a sort of break to the expiration. This change modify the way the patients are breathing, and this is why, when using this device, you can see quite constantly a drop in respiratory rate. For the same mechanism, there is some PEEP, which is created inside the upper airways, and of course within the lung. This device is also able to wash out the CO2, so decrease the inspiratory effort, and very comfortable for patients, and may also improve the mucociliary clearance that can be particularly important after extubation, as Arnaud told us before. Sometimes cough and presence of secretion is one of the problems we have to cope with after extubation. All these devices can be used, and they have been used in the context of different strategies. Okay, but when we talk about prevention, and I would include also treatment of post-extubation respiratory failure, where I essentially talk about the so-called prophylactic or preemptive strategy and also curative. Preemptive means that we want to use these devices before the occurrence of post-extubation respiratory failure with the aim of preventing the occurrence of post-extubation respiratory failure. So, in general, with the prophylactic strategies, this means that patients are extubated and automatically put under this any form of non-invasive respiratory support to protect extubation. The other strategies is the curative approach, and this is when you have done nothing before and the patients have developed post-extubation respiratory failure, and then you have to treat this post-extubation respiratory failure with this device. So I will talk a little bit about the use of this device in these two contexts. First of all, prevention. And Arnaud really have to be commended because it improved a lot our knowledge in this field. In this case, for example, there are several studies in this context, but one of the problems was about non-invasive ventilation. Was non-invasive ventilation used as a preemptive strategy able to reduce the reintubation rate also according the presence or absence of risk factor for extubation failure? And in this study, for example, this was very simple. I like very much this study, even if it's not randomized controlled trial, because they included patients, and this was a before and after study. In the first period, all extubated patients were put under oxygen. In the second phase, all patients were extubated using NAV as a prophylactic strategy to prevent post-extubation respiratory failure. And they look at the outcome based on the presence or absence of risk factor for extubation failure. And the risk factors were very simple: being older and having any cardiorespiratory disease as a comorbidity. Very, very simple. And what they found is that if you look at the line, the dotted line, in blue and green, these are the outcome in patients extubated with oxygen and with NAV. In patients without risk factors, there is absolutely no difference. The reintubation rate on average is 10%. But when you consider patients with risk factor for extubation failure, then the reintubation rate decreased from around 30% when they were extubated on oxygen to half of the rate, 15%, when they were extubated under non-invasive ventilation, clearly underlying the efficacy, usefulness of this technique to prevent reintubation. And this, I say, this is one of the studies, but other studies were done in this context. And this is a meta-analysis associated with the publication of the guidelines about the use of non-invasive ventilation in different contexts. And from this meta-analysis, clearly you can see that mortality may be reduced by using NAV to protect extubation in patients with risk factor, which motivated this recommendation, which is a conditional recommendation, so it's suggestion to use NIV to protect extubation in patients with a risk factor for post-extubation respiratory failure. Then iFlow was used also for this. But at that time, we have two conditions. We had one thing clearly in mind, that patients without risk factors, they probably need nothing, while patients with risk factors will benefit from the preventive use of non-invasive ventilation. And then the studies that have compared, that have assessed the efficacy of iFlow, were compared to different things: oxygen in patients unselected without risk factors, or versus NAV in patients with risk factor for extubation failure. You can see on the left also the presence of risk factors is not so easy because we have many definitions of risk factors of extubation failure. Many studies used different risk factors. I think that is very straightforward to use some simple thing like age and cardiorespiratory comorbidities. So in a first study, in 2014, we first compare iFlow to Venturi mask in patients with showed a moderate hypoxemia after extubation. And in this study, we showed that actually iFlow was able to improve oxygenation in this patient as compared to the Venturi mask. And we find also that with iFlow, the reintubation rate was lower. And this effect was quite evident and also quite unexpected. And indeed, these results were also confirmed by a subsequent multicenter randomized control trial by Gonzalo Hernandez in Spain that showed that in patients without risk factors for extubation failure, the reintubation rate decreased from 12% with simple oxygen, any form of oxygenation devices, versus 5% when using iFlow. More recently, we have published last year this study, because which was let's say the natural evolution of our first study, in which we compared again iFlow to Venturi mask in patients with moderate hypoxemia after extubation, with the specific aim to see if the two strategies were associated with different reintubation rates. And this was contrary to our hypothesis. We did not find any difference between iFlow and Venturi mask. And there were some aspects that may justify these results. First of all, the reintubation rate on average is very low, much lower than we expected in the control group. And also, another thing that was different is that we allow to use rescue non-invasive ventilation to treat post-extubation respiratory failure in both groups. And we did this based on standardized criteria. And what we found that indeed, even if the reintubation was similar, there was a lower use of rescue non-invasive ventilation with high-flow nasal oxygen. So in any case, there is some advantages. In patients with high risk for respiratory failure after extubation, Gonzalo Hernandez again published the results of non-inferiority trial comparing iFlow and non-invasive ventilation in patients at risk for post-extubation respiratory failure. And in fact, that study showed that iFlow was non-inferior to NAV. More recently, there was also this post-hoc analysis of the study that Arnaud T showed us before, comparing iFlow to the combination of iFlow plus non-invasive ventilation. And this was done in obese patients, and in obese patients in particular, non-invasive ventilation associated with iFlow is much better as compared to iFlow alone in protecting extubation. So this is also important and underline the use of non-invasive respiratory support to protect extubation. Overall, iFlow in the meta-analysis is better than oxygen and no difference from non-invasive ventilation, which justify these guidelines that say in patients without risk factor, you can, as compared to oxygen, and you can use, it is suggested to use iFlow after extubation in patients that have been intubated for more than 24 hours and have any form of, any kind of risk factor for extubation failure. While compared to NIV, the suggestion is to continue to use to NIV as opposed to high-flow nasal oxygen in patients, for patients in who clinician would normally extubate to non-invasive ventilation. But this means that, for example, if tolerance and comfort is a concern, high-flow can be used as an alternative. Concerning the curative effect, we know with this study that actually using NIV to treat post-extubation respiratory failure is not useful and may be dangerous, actually. And in fact, the recommendation, that guidelines that we have are against the use of non-invasive ventilation as a rescue treatment for these patients. However, because, for example, in our study, we use NIV as a curative strategies, we were concerned if patients who were intubated after using rescue non-invasive ventilation as a worse outcome as compared to those directly extubated, directly reintubated without NAV. And fortunately, indeed, the outcome of patients directly reintubated or reintubated after non-invasive ventilation was not different, as it was not different also the outcome of patients reintubated early as compared to those who were reintubated late. So, no data about the use of rescue high flow. So in conclusion, I think that all the systems that we have for non-invasive respiratory support may help in preventing winning failure. Both high flow and NAV are recommended actually as a prophylactic strategy in high-risk patients. I think that is important to stress the importance to individualize the treatment and also to carefully monitor these patients with whatever kind of respiratory support, because delaying intubation, of course, is associated with the worst outcome. Thank you. Thank you very much.